Recording in progress. Good afternoon and welcome to today's Michigan Medicine Well-Aware presentation. We look forward to providing updates about advances in cardiovascular disease and ways to improve your heart health across all stages of your life. We have an expert group of panelists with us today. Let me also say thanks to all of you who submitted a question on the RSVP form. We will be working to answer many of those throughout the presentations and later during our Q&A. We will also be accepting live questions during the Q&A portion of today's presentation. For those of you who are joining us through Zoom, please use the Q&A feature to ask your questions. We will do our best to get as many as possible. So, without further ado, let's introduce our panel. First up, we have Dr. Kim Eagle, Albion Walter Hewlett Professor of Internal Medicine and Director of the Frankel Cardiovascular Center, and he'll be discussing the importance of philanthropy and Project Healthy Schools and our efforts to address cardiovascular disease in our community. With us, we also have Dr. Rick Oye, Vice Chair, and Edward L. Bove, Professor of Cardiac Surgery, Head, Section of Pediatric Cardiovascular Surgery, Co-Director of the Michigan Congenital Heart Center, talking with us today regarding the unique and specialty care provided to our littlest victors with heart disease by the multidisciplinary team at the Michigan Medicine Congenital Heart Center. Also with us is Dr. Monica Colvin, Professor of Internal Medicine and attending in advanced heart failure, transplant, and mechanical circulatory support, chatting with us today about clinical and research efforts related to heart failure and heart transplant. She's also providing insight into maintaining cardiovascular health with a diagnosis of heart failure. And lastly, we have Dr. David Pinsky, the J. Griswold Ruth, MD, and Marjorie Hopkins Ruth Professor of Internal Medicine. He'll be discussing with us today COVID in the heart and research advances that enable proactive prevention and management of cardiovascular disease. And now I'd like to invite Dr. Eagle to join us for his presentation.
Thank you very much. It's a pleasure to be with you, all of you, and look forward to this chance to discuss heart health. I think we're going to start today with a question just to get a sense for how cardiovascular disease might have influenced your lives. So here's a poll. Have you or a loved one been affected by cardiovascular health issues? Please answer that. And I'm betting that probably every one of you has. And of course, at least until COVID, cardiovascular disease was the #1 killer of men and women in the world. COVID has overtaken it for the moment, but hopefully as we get steady progress in the area of vaccines and so forth, we'll see a shift back. Yes, 90% of you said that cardiovascular health has directly affected you. You know, I was thinking today about telling what I thought would be a heartwarming story about cardiovascular health and how a great university like Michigan is connecting with its community. Nearly 20 years ago, we had a couple of members of the school board were patients of mine, and we were thinking about how can we bring heart health into our schools? And this is, of course, a very interesting dilemma. PE has largely gone away, at least in middle schools, and the ability to bring heart-healthy food into cafeterias and so forth has been a challenge. And we were interested in working with our preventive health group at the university to see if we couldn't make a difference in the heart health of middle schoolers in our city and then in our state. So how do you engage 12-year-olds in heart health? And we designed a school curriculum which included 10 in-home room lessons that are highly interactive. And they teach students about the value of activity, eating more fruits and vegetables, reducing things like extra sugary beverages and fatty foods, spending less time, mindless time, if you will, in front of a computer, and so forth. And with that program, we did a pilot of a program in Clegg Middle School here in Ann Arbor called Project Healthy Schools. And we were able to show that the children really enjoyed learning about heart health and they engaged in it. We also worked with the cafeteria and the principal and teachers to try to think about how can we celebrate heart health in this school. We measured what happened. We had the kids do step tests and we watched what happened with their blood pressure and their fitness and their cholesterol and their blood sugar. And the program worked. And it was very exciting. And we asked the school district here in Ann Arbor to allow us to work with all of the middle schools in Ann Arbor, and they agreed. And subsequently, we expanded to Ypsilanti and continued to ask the question when we work with students using the school as the place where we learn and try to get more healthy, can we see better outcomes? And we did. And ironically, in schools in parts of our communities where there were less resources in terms of parks or full service grocery stores, we saw the effect was even greater. We were very fortunate that the philanthropic community became interested in this. The future of our state, of course, is our children. And so Blue Cross Blue Shield, the state of Michigan, many individuals, many donors jumped on. And over a period of the last nearly 20 years, we've been able to see a steady growth in the application of the Project Healthy Schools curriculum to the state of Michigan. So far, we've reached over 140 middle schools over the last 20 years. Currently, our program is in 106 middle schools, and the program has reached nearly 47,000 students. And we've been able to measure student attitudes, as well as for many of the schools, what happens with things like blood pressure, blood sugar, cholesterol, and have been able to show that the program appears to work. Not only that, we were interested in whether or not it might work in terms of a sustained effect. What happens when the kids leave middle school and go into high school? And we were heartened to see that the improvements we saw in blood sugar and cholesterol, for example, continued to be realized after the students graduated from the middle school. So I think Project Healthy Schools is an example of where a university partners with the community and philanthropists and leaders to try to take on a public health challenge, which is so ubiquitous in our society. And we've been very, very fortunate to work with many, many partners in this endeavor and hope to continue to expand this program in the future. So I think Project Healthy Schools is an example of how universities and communities can work together. I was delighted that our team last year was awarded the President's Award for the most impactful community program. And just this past 6 months, the governor gave us one of the governor's awards for programs that really attack the improvement in fitness among our youth. So I wanted to bring that story to you today, and I appreciate a chance to be with you on this well-aware webinar.
Thank you so much, Dr. Eagle, for that. Thank you for sharing your passion for philanthropy and also, of course, the wonderful work Michigan Medicine is doing in our communities around the state of Michigan. So we have had Dr. Eagle's presentation, and now I would like to welcome Dr. Rick Oye for his presentation. Dr. Oye.
Thanks, Ed, and thanks to everybody who's on the call today. Appreciate it. Again, my name is Rick Oye. I'm one of the pediatric cardiac surgeons here, and it's my honor to represent the Congenital Heart Center in this talk. I'm going to give you sort of a broad overview of what we do in the Children's Hospital with our congenital heart program. This is the Mott Children's Hospital. It's roughly 1 million square feet. It opened about 7 years ago this winter. There are 5 clinical floors, of which we occupy 1.5, so we're a pretty big footprint of the entire Children's Hospital. We are a big program. We're one of the biggest in the country. We have served patients from all 50 states, including Alaska and Hawaii, which are not on this map, and over 60 countries. This is for our mission and vision, and this is basically what we do every single day at the Congenital Heart Center. We provide patient care, compassionate patient and family-centered care We do research, collaborative, innovative science and discovery, and we educate the next generation of physicians that will care for these patients. And I'm going to go over a little bit of each of these. And
Dr. Oye, can I just interrupt you for 1 second? I don't know that we can see your slides.
Oh, well, let's try that again.
Yeah, let's try one.
I have share screen and share.
Looks good now. I can see them now.
Yeah, I don't know why that didn't work. Sorry about that. You'd think I'd be pretty good at running Zooms by now. But at any rate, this is our mission. I went over the three, and we're going to kind of go in reverse order. I'll talk a little bit about education. There are a lot of congenital heart programs in the country that teach, and I think we're easily considered one of the top congenital heart surgery programs in the country. And the same goes for my medical colleagues on the pediatric cardiology side. I'll give you an example of the roughly 30 fellows that we've graduated in congenital cardiac surgery. 9 now run programs of their own. So that's a pretty good track record. About the third of the people that we graduate go out and have now gone on to lead their own programs. And things like education, this is a development event, and we would welcome support from anybody who's interested, not only for funding, but we're also interested in fundraising. Anybody who's interested in getting involved, we'd welcome all of you to join us. And in education, there isn't federal funding. The med school doesn't pay for these fellowships. We pay for them out of our clinical revenue and through philanthropy. So really an important part of what we do. The second thing that we do is research. And I'll just sort of tell a little story. And again, research is not federally funded to the extent that we need to. Only about maybe 3% of our entire research budget goes to kids with congenital heart disease. Really hard to believe when this is the #1 birth defect in the country. So it's incumbent upon us to raise the funds to advance the entire field through research. And so here's a little story. This is Amelia and Sarah Beth, and they didn't always look like this. In fact, this is what they looked like when they were born. They were conjoined twins. They were joined from just below the belly button to the top of their chests. And so how did we go from here to here? Well, obviously we took them to the OR, and this is us separating the twins. That's me in the middle operating, and we're being assisted by George Mielishka and Marcus Jarbo, which underscores what a team effort this is to take care of kids with congenital heart disease. Because oftentimes, even for kids who have quote unquote isolated heart defects, they have a lot of other things going on, need a lot of other care. So it's really a multidisciplinary effort. And this is the team, or even not even the whole team, that morning of that surgery: pediatric surgery, pediatric heart surgery, plastic surgery, anesthesia, nursing, respiratory therapy, perfusionists, you name it. A really big team effort to get these kids the kind of results that we want across the board for all of our children. And it even
Dr. Oye,
yes.
I'm sorry. One more thing. Could you make it a full screen? I can see your images, but I'm not sure that everybody can see all these fantastic pictures.
Are you looking at the?
We see the preview slide on the right-hand side and a smaller slide on the left-hand side, so it doesn't look like it's full screen.
Okay. Well, I can fix that too.
Yeah, it looks like a split screen.
Yeah, it should be screen. I can try the other screen. Good thing we practiced this just before we started.
There we go. We've got it, and I promise I will leave you alone.
That was puzzling the last time, right, when we were getting this all set up, why it was the wrong screen. But all right, are we now on this screen where my cursor is?
I see it.
All right, beautiful. All right, so like I said, it spreads even outside the operating room, and without technology like this, these sort of operations wouldn't be possible, frankly. And these are actually from a radiologist who does predominantly adults, but he has expertise in 3D imaging and printing 3D models. And so these are the twins right here. And what you see is, if we take away the soft tissue, you can see the bones and you can see some of the organs. And the bones are important for me because I needed to know how to separate them and how to then reconstruct their chest wall. You can take away the bones, and they shared a liver, and so the ped surgeons need to know how to separate their livers, and we actually also printed out models of this. And then we need to know the blood vessels too, because We needed to know where there were shared vessels that we're going to have to cut across. And so all of this is innovation that only exists because there are people who work at the University of Michigan who are interested in advancing this, and with the support of philanthropy. So the last thing we do is, of course, we take care of patients. And I want to tell just a little story about that, because really what we do is we take care of the child through their continuum of their life. It's even if you have a heart surgery early on, we're still caring you for your entire life, and we're caring for your family too. So here's a little story. This is Trenton. So Trenton had his first surgery at birth with us, and then had 3 planned surgeries in order to get by. He was a very, very complex congenital heart disease. And people will say, so why do you do this? What's your goal in doing this? And really, we want kids to just be kids. We want them to be able to ride ponies. Here's Trenton, a little bit older. We want them to go win ribbons in 4-H. We want them to be developmentally intact. We want them to be mentally developmentally intact. We want them to be physically intact. We want them to be emotionally intact, behaviorally, so they can grow up, do all the kids things that they should do, go to school, have relationships, get married, have kids of their own. And that's a little different, I think, than how it works on the adult side. And again, we're treating the whole family. This is Danielle's mom, or this is Trenton's mom, Danielle. And when we treat these kids, we're not just treating the kid, we have to treat the whole family. We're supporting them. We're treating the entire family, including their siblings. And this is Trenton today. And he is graduating from high school. And, I think I'm going to use an email from Trenton's mom, Danielle, because I think I can't say it any more or any better than she said it, and really the importance of what we do. So I'll close here, but I want to read this email from Danielle. So Trenton, he turns 19 today. I remember talking to you in the ICU. You gave us a 25% chance, but said you'd do everything you could. You did. He's fantastic. He's healthy. Heart and lungs are great. This year, I get to watch him graduate from high school. I get to move him to trade school in August. He's been accepted into the John Deere Diesel program, and I couldn't be more excited. You gave this to me, and I couldn't thank you enough. And of course, it's not me. It was the Heart Center that brought this to her, and all the things that we went over previously, all the education, all the research, and all the patient care. So with all the delays and having to get this up, I'm probably a little bit over time, so I'll quit there. But thank you very much for being on the webinar. I look forward to hopefully working with you all in the future.
Thank you so much, Dr. Oye. Thank you for that. And I'm happy we got those slides bigger as well. It's wonderful to learn about what makes the Michigan Medicine Congenital Heart Center really unique in its class, and how it's dramatically improving outcomes for our littlest victors. It's no surprise that the center continues to be the highest rated pediatric cardiology and heart surgery program in Michigan, and also one of the top rated centers across the nation. And now I'd like to welcome our next presenter, Dr. Monica Colvin. Dr. Colvin.
Thank you. And thank you for the opportunity to speak today about heart failure and some of the research that our group is conducting. A patient once told me that heart failure was too negative a term. So today we will focus on success with heart failure. Next slide. First, what is heart failure exactly? And some of you may have experience with heart failure or may know someone who has heart failure. Heart failure is the most common reason for hospitalization in the United States and affects over 6 million Americans. It refers to weakening or stiffening of the heart muscle, and it occurs when there's substantial injury to the heart, such as in a heart attack or with uncontrolled blood pressure. So when the heart becomes weak or stiff, it becomes unable to pump adequate amounts of blood throughout the body. And this results in symptoms of shortness of breath and fatigue, congestion, cough, and swelling. Patients with heart failure will oftentimes experience reduced exercise capacity. They may develop breathlessness with even small amounts of activity. And ultimately, this can result in not being able to work, not being able to go to school or be active, and decrease productivity overall. Next slide. The best treatment, of course, is preventing heart failure. And if you don't have heart failure, we recommend maintaining a healthy diet in order to prevent the development of heart failure. In addition, for those patients with conditions such as high blood pressure and diabetes, controlling these conditions by taking medications as prescribed can reduce the risk of developing heart failure. Next slide. Today's medical therapy is highly successful and has reduced mortality by 40%. And with the current therapy, the latest and greatest that you may see sometimes on TV, there's improvement in survival and reduction in hospitalizations. The therapy also improves heart failure symptoms and can sometimes even improve heart function back to normal. So many of our patients are able to feel better, get back to work, and participate in usual activities. Patients who have coronary blockages or valvular heart disease that contribute to their heart failure may benefit from having those conditions fixed. And for those who are unresponsive to usual therapies, we have advanced therapies, which include heart transplant and heart pump, or what we refer to as mechanical circulatory support. And what this refers to is a pump that's typically implanted into the left side of the heart to take over the function of the heart. This also includes the total artificial heart pump. Next slide. The University of Michigan has a long-standing and highly successful mechanical circulatory support program that has received national accolades. We perform about 50 to 60 devices per year, and we've had excellent outcomes. We've been involved in all of the pivotal ventricular assist device trials. And currently we're using the latest model, which is the HeartMate 3 pump that's shown there above in the middle. This is the newest generation device and has decreased some of the most significant complications involved with associated with pump technology. The most serious complications include stroke or pump clotting and bleeding from the GI tract. And this new pump was designed to reduce the friction on blood vessels. And as a result, the risk of stroke with this pump has been significantly reduced. However, bleeding from the GI tract it remains a serious problem. And some of our research at the University of Michigan focuses on ways to reduce complications of bad technology, such as bleeding. So one of my colleagues, for instance, Dr. Bitar, has a novel study that's investigating the role of omega-3 fatty acids in reducing bleeding in patients with heart pumps. Next slide. Heart transplant is considered the cure for heart failure and can extend life by greater than 10 years. And in some patients, much more than that. We have a very successful program with excellent outcomes and perform between 30 and 40 transplants per year. One of the barriers to longevity of heart transplant, however, is the development of a type of coronary disease that's specific to heart transplant recipients. And this can cause failure of the transplanted heart. Currently, there aren't any effective treatments for this type of disease, and some patients may even end up needing a new heart transplant as a result. We have a system-wide solid organ transplant biorepository where we collect samples from transplant recipients. And as part of that effort, we're investigating the role of immune cells that are involved in the development of coronary disease after transplant. And this will help us understand critical pathways that are involved and hopefully lead to effective treatment strategies. Next slide. If heart transplant is successful, then why doesn't everyone who needs one get one? And that is the question of the day. And one of the reasons for that is the lack of availability of donors. The demand continues to exceed the supply. And one of the reasons for that is that the period of time that a donor heart is usable and viable is limited to about 4 hours. Currently, heart transplants are performed when a donor has ceased to have brain activity, but not after their heart stops beating, because once the heart is removed from the donor, once it stops beating, the clock starts ticking. And the longer the heart goes without being perfused, it can create injury to this heart that's irreversible. So if there was a way to extend the life of those hearts, we could potentially increase the availability of donors by 20 to 30%. And this is a very exciting prospect for those patients who are awaiting transplant, because we still have significant numbers of patients dying on the wait list for heart transplant. The technology shown above allows for a donor heart to be kept warm and functioning for a longer period of time, which prevents irreversible injury to the heart, and allows for a heart to be used even after the 4 hours and even extends the distance to which that heart can be used. So with this technology, donation after circulatory death is possible, and Dr. Pagani, the surgical director of our VAD program, is leading this innovative effort. Our clinical efforts in heart failure have expanded to serve the needs of patients around the state. We have a heart failure outreach program in Midland and have recently developed an inpatient program for lower acuity patients in Chelsea. So with that, I'll end and hopefully have provided some exciting highlights of our clinical investigative innovations of our program. Thank you.
Thank you, Dr. Colvin. You definitely did. We're really grateful for your leadership and your dedication to supporting our patients and families at critical times during their care. Last but not least, I'd like to introduce everybody to Dr. David Pinsky. Dr. Pinsky.
Welcome to our webinar. I have to tell you, I'm just enraptured by hearing from my wonderful colleagues all these exciting advances. So it's really an exciting time to be a cardiologist and to be in medicine. What I'm going to start by telling you about, I'm going to talk just a little bit about COVID because no question it's still on everybody's mind. But I also want to tell you about other heart issues and the research that we're doing. I want to focus on research. So next slide, please. So the Cardiovascular Center, we were most fortunate because of philanthropy to be able to turn on a dime. And when COVID was washing across our shores in our nation, this is starting even early in April, we were able to pivot and do some very rapid fire investment and research. And here are just a few of the highlights. Dr. Salim Hayek published a very impactful study. This was July. Remember, COVID was really starting around March to April here, and this is already a publication in one of our highest impact journals. And what he's looking at in this study and continues is a blood protein. It's called SUPAR, and this protein predicted who was coming into the emergency room with COVID who might have a cardiovascular or other collapse. If you know early somebody's going to do poorly, then you can give them intensive therapies early. So this was one of the very earliest studies in COVID from our health system, and very impactful. Next. Doctors Knight, a rheumatologist, and Canthi, a cardiologist, have some very exciting ongoing work. Here is a work on something called neutrophil extracellular traps. I think most of you know or might have heard that when the SARS-CoV-2 virus, that's the virus of COVID, when it infects your body, one of the problems is your immune system goes on such an attack madness, if you will, that there's a lot of destruction to normal healthy tissue. And that's called a cytokine storm. It's a storm for a good reason because it creates a storm in your body, and sometimes patients don't survive the storm. And what they show here, and you can see it in this picture, is the white blood cells, when they're normally trying to attack invading organisms, one of the ways they attack is sometimes they commit suicide and they explode and essentially vomit out their contents, their sticky DNA contents. Those are called neutrophil extracellular traps. It's like Spider-Man might spew silk to capture a crook. This captures bad bugs. It creates a sticky tangle of net. But if this happens in a lot of different places in your body, it can also form clots, and it can create havoc. So what's meant to be protective, if it goes haywire and excessive, it creates these traps. And you see those here. That's the green you see with those arrows. These are these nets, and this can cause clotting. And as we know, clotting is a major issue in COVID. And so we have actually several investigators who are looking at how do we stop the blood from clotting excessively. Dr. Obi is doing that from vascular surgery. And then there's a new trial of an old agent that's used for stroke, a trial called DICER, which this work led. That's a national study of a treatment for COVID. So next, you see it's highlighted in a lot of news organizations. And last but not least, there are many of these studies, but just to point out that Dr. Cascalho from surgery, one of the world's leading B-cell immunologists, has isolated antibodies from recovering patients and has developed at least a potentially very effective therapy that's very powerful. one of the reasons the vaccines are working in us is because they create a whole panel of antibodies in our bodies. But she and her team have identified several, you can see here, 43 distinct antibodies that have very powerful binding to the virus to knock it out. So those are just some examples of the research we've done in COVID. You can turn off the slides now, thank you. So it's a very, very exciting time for us because research is so fundamental to what we do. And I have to say, sometimes the American public questions the value of fundamental research. But I think at this moment, when COVID is really such a scourge across our nation, across the world, we are so fortunate to have the research that people did before us. The Nobel Prize given for the development of the polymerase chain reaction, that's the basis for testing in COVID. That's how we can rapidly develop novel vaccines, because we actually take the DNA strand template and then we can actually make it so in a way that when it's injected in the form of a vaccine, we form antibodies and protect ourselves. So fundamental science is so important. And at Michigan Medicine, this is something that we do very well. We do it with the people who take care of patients, myself included, and others. We do it with basic scientists and really across this great campus with many disciplines. Why is this important for cardiovascular disease? So turning to general cardiovascular disease, it's still the #1 killer in America. It's a huge problem. And despite modern therapies, people still die. They die of heart failure, as you heard from Dr. Colvin. They die of heart attacks, strokes. How do we prevent it? So preventing heart disease is very important. I'm going to just briefly, in my last few moments, talk to you about the work of one Dr. Kristen Willer. She's a PhD scientist, one of the most illustrious scientists in the world, studying the genetics. She studies genetics of lipids, among other things. And what she has done is she's actually studied patients and gathered samples from thousands of patients to understand how blood lipids might create conditions for heart attacks or strokes, and then possibly leading to new therapies. There's some very interesting therapies that were based on genetic findings. So having an expert like Dr. Willer and her team to understand human genetics to possibly lead to absolutely novel drugs is something we're very proud of. So we're going full force with that. And to let everybody know, fundamental research is important, and the presence of great colleagues, intersectional domains, and just having generous people who believe in us allows us to do wonderful things. So thank you for your time and your attention.
Thank you so much, Dr. Pinsky. We covered a lot of information in a short amount of time with your presentation. I also know we've got lots and lots of questions awaiting us. So it looks like we have all the panelists back on the stage. And I'd also like to note that our panelists cannot give personal patient recommendations, but can give generalized medical advice. So let's now dive into the Q&A portion of this webinar. The first question that I have up is for you, Dr. Pinsky. Some people are still uncertain about symptoms of heart attack in women. Could you please elaborate on things women can be aware of?
Absolutely. Well, thank you for the question. It's a really important question because, as you heard early in the presentation, more women die of cardiovascular disease than any other cause, including all the various cancers and other things. So very important for women. And in this Heart Month, let's not forget to focus on that. Women can present with classic symptoms. So let me start by telling you classic symptoms. If somebody has a heart attack, chest pain, chest discomfort, sometimes it feels like indigestion, sometimes it's a shortness of breath. Those can be classic symptoms, maybe fainting or something like that. But for reasons we don't really fully understand, women sometimes don't present that way. A common presentation is excessive fatigue, right? It's not described as chest pain. It may be that women are often stoic and don't even realize it or aren't used to saying things. So fatigue is one. they can present with the classic symptoms. I think being aware of your own body, knowing what you feel like, and if something feels different, please call that to attention and recognize that this affects women, not just men. So take care of yourselves and pay attention to your bodies. That's the message.
Thank you for that, Dr. Pinsky. Does anyone else have anything to add to that question? We can jump straight into this. Oh, no, sorry, go ahead.
No, I was just going to say, so Dr. Colvin, so heart failure is the most common reason that patients get admitted to the hospital. Do you see any differences between women and men in heart failure when they come in?
I'm unmuting. So I think it's very similar in that sometimes symptoms may go unrecognized, or women may present with symptoms that may not necessarily be typical. What we generally see, as opposed to women who have heart attacks and angina, is that sometimes it's misdiagnosed. So it's thought for years to be something else, such as asthma or some other type of condition. So the important thing is when someone is experiencing shortness of breath or fatigue, that they seek help, so that we can diagnose heart failure in a timely manner. Yeah.
That's great. Thank you.
Mm-hmm.
Yes, thank you for that, Dr. Colvin. Let's move on to our second question for you, Dr. Eagle, and it is a three-parter, so I can definitely repeat it again, but I wanted to put all of it out at first. What is the latest on a heart-healthy diet, and is it enough? What are your thoughts on exercise, particularly for older adults, and what about individuals with disabilities, such as mobility issues?
Yeah, those are all really important questions for all of us, aren't they? I think the current research around diet really suggests that a diet that is more focused on plant-based is healthier than one that's more focused on, say, marbled meats. We tend to recommend a Mediterranean diet, which is typified by lots of fruits and vegetables, beans. If for protein, fish and poultry would be perhaps better than marbled red meats or processed meats. We need to pay attention to salt, particularly if there's a tendency to high blood pressure. That's a really important target. And if the cholesterol is high, we're really thinking about fat and trying to reduce fat in the diet. And obviously, for somebody who has a diabetes tendency or metabolic syndrome, we're thinking about the sugar. So what we try to do with our dietitians is really think about a person's individualized situation and then try to tailor the diet for them. But salt, fat, sugar are high on our thinking. Activity. You want me to address activity in 2 seconds or less? The first thing I like to do is really say, I want my patients to move. Some of us are sort of allergic to the notion of exercise, but the idea of movement is acceptable. And that can be a 30-minute walk every day. I walk my dog for an hour. That's terrific. I like my patients to get 10,000 steps if they're walkers. If they want to be more intense, we would like to get them to do 30 to 45 minutes of moderate to high intensity exercise 3 or 4 times a week. There's no doubt that movement is incredibly helpful for cardiovascular health, and it has a lot of other aspects too, bone health, mental health, things like that.
Dr. Eagle, can I just ask you a follow-up, because diet is so important. So as a cardiologist like you, often my patients, they take a statin drug, a very common drug to lower cholesterol, and they feel it gives them permission to eat unhealthy. How would you address that?
Great question. So the first thing to say is I think that we want to get patients generally moving in the direction of health. I also believe that an occasional holiday is acceptable. And so if they say to me, I really want to have those barbecued ribs once a month, and we have good control of their cholesterol, that's terrific. To get to your specific question, it looks to us like diet and drug are complementary. They have different effects on the development of coronary plaques, the growth of coronary plaques, and plaque rupture. So excellent diet plus, where appropriate, medications like statins are complementary in their ability to reduce risk. I would like my patients to stay disciplined with diet. Having said that, I fully admit that there are those among us who occasionally, because our cholesterols are so great on a statin, will have a bit of a holiday.
Thank you.
Thank you for that, Dr. Eagle. Let's move on to Dr. Colvin for our third question. I'll pass this to you first, Dr. Colvin. After a heart attack or heart transplant, what can you do to prevent a second event or complications?
Okay, well, I'll address the heart transplant first. And the theme is pretty much the same for all of cardiovascular disease and how to prevent it. But a heart transplant replaces a damaged heart and it cures heart failure. But it doesn't mean that you can stop taking care of your heart and stop observing healthy measures. So we continue to advise our patients to follow heart healthy diet, to remain active, not smoke, maintain a healthy weight, all of those things that we recommend for preventing cardiovascular disease in general. And those things are also recommended to prevent a recurrent heart attack. Heart transplant patients, similarly to patients who have had a heart attack, are advised to take statins and aspirin to prevent the development of coronary disease. Transplant patients can develop a specific type of coronary disease that we see in transplant recipients, and they can develop usual coronary disease like patients who have had a heart attack. So the treatment is pretty similar. Take the medications as prescribed that will prevent heart disease, treat blood pressure, treat diabetes, observe a healthy lifestyle, don't smoke, all of those things.
Thank you for that, Dr. Colvin. My next question is for you, Dr. Oye. As a pediatric heart transplant patient transitions into adulthood, what programs exist to help that patient become an advocate in their own heart care?
Well, thanks for that question. That's a really great question. And I'm going to expand it to basically all kids with congenital heart disease. And congenital heart disease just in general is the most common birth defect. It is much more common than, say, childhood cancer, for instance. But we hear a lot more about childhood cancer. But now we actually have more adult survivors with congenital heart disease than we have new kids born every year. There's estimated to be, in the United States alone, somewhere between 1.5 to 2 million adult survivors of congenital heart disease. So it's a really timely question because that population is growing much faster than the number of children. So the longitudinal, long-term, as I kind of alluded to in my little slide presentation, those slides that you could see, I guess, was to cover all the kids. We take care of them from when they have their surgery, even if it's as a baby, all the way through adulthood. And so adult congenital heart care is actually a brand new official specialty. There's now a fellowship, or one of the few programs in the country with a fellowship to train those doctors who do both training in adult cardiology, like my colleagues on this panel, and in pediatrics. And it's a boarded specialty. And so part and parcel of that is that transition program that we've developed, not only at our program, but all big centers have now a transition program, which helps empower kids who have chronic diseases, whether it's heart disease in our world or other things like childhood cancer, to begin to take on their own care. It is a difficult thing because their parents are used to taking care of them, and they're used to being taken care of by their parents. Things like making your own appointments, being responsible for your own medications, not just taking them, but ordering them. They're all things that are super important during that transition, and frankly, sometimes difficult. So I think it's a really good question, and we do have specific programs to aid in transition.
I want to just add to that, Dr. Oye. It's a wonderful program. You know, because of surgeons like you and nurses and technical staff who help, these kids are living and they're coming into our adult domain, and it's really exciting. One of the ways we help with that psychological transition is the doctors take care of them in women and children's at Mott Hospital, and then the same doctors come over here to the Cardiovascular Center where they have their clinic. And so although the setting is different and they're grown-ups around them as other patients, we try to keep the doctors the same. And I think it really does help psychologically as they grow up. And we're most fortunate they can grow up because of the work you and your team does.
Rick, your comments also just make me think about adults who are entering cardiovascular care for the first time. And the whole notion that a big part of our work is to get them to feel empowered to own their illness. They need to own taking their medications. They need to own decisions every day about movement and diet, what they put in their mouth, and their follow-up plan. And for patients that are entering the cardiovascular health care in general, I spent a lot of my first visit talking about empowerment. This is your illness. I'll be delighted to be your coach, but you're fighting the battle on the field. I'm on the sideline just helping you imagine how to win that game. And that's a really important part of the transition you talked about. And it certainly is also important in adult care.
And I'd like to add to that, Dr. Pinsky mentioned how sometimes women present differently, and this can lead to delays in diagnosis, and this being Go Red Month, where we tend to focus a little bit more on women's health. I think it's very important for everyone to be an advocate for their health, particularly populations that may be at risk. And so arming yourself with information, which is out there. Some of it is not so good, but a lot of it is very good information. And I feel like the more you know, and then discuss this with your doctor so that if you have concerning symptoms, maybe they will not be missed, but also taking ownership of your care and participating with your doctor in the management of your condition.
Thank you. Thank you all four for your answers. They've been fantastic. The next question that we have up is for you, Dr. Eagle. First off, how does alcohol affect heart health?
It's a great question. Because of the tendency for alcohol to be a challenge for some of us, physicians generally are reluctant to recommend alcohol from the point of view of prevention. If you look at populations studied over time, it looks like at least for the average person, for a woman, 0 to 1 drinks of alcohol per day is probably not harmful, and for a male, it's 0 to 2, and probably focusing more toward the 1. However, there are situations where alcohol may be more of a problem. Alcohol, when steadily used, can raise blood pressure. So in patients who have a tendency to high blood pressure, I really try hard to think about limiting alcohol. Also, alcohol can be a little bit of something called a proarrhythmia substance. That is, patients who have a tendency to irregular heart rhythms, alcohol may tend to make that worse. So there are at least a couple of circumstances where alcohol has particular issues where we would try to limit it more. But in general, mild consumption of alcohol is not particularly harmful to your health unless it becomes more excessive.
Thank you for that. Next question I'm going to push to Dr. Oye. How do you assess a patient's condition over time? Particularly, how do you monitor or treat if it is something hard to diagnose or can perhaps worsen?
Yeah, so another great question, because as I mentioned, we're like, if you take Trenton, had his first surgery within the first week of life, but we continue to follow them for a lifetime, all the way through, even when they're out of childhood into adulthood, as we just talked about. In sort of a more practical sense, we ask that these patients understand that they always need to be seen by a pediatric cardiologist, even when they're not pediatric patients, because they have special needs in terms of what their physiology, oftentimes it's unique. And the way they're followed are some of the routine things would be like ultrasound, for instance, would be the most common, or echocardiography, as we would say. MRI is one of the new gold standards of how we follow things as well. So that's sort of the everyday clinic, coming to see your pediatric cardiologist. I think one of the more important things that we do, though, is looking in terms of longitudinal care, not just to look at the heart, because these kids do have other challenges. They have challenges with their neurodevelopment, their mental development, their physical development. And so we have programs, a longitudinal outcomes program, where we follow these kids along very, very closely. We make sure that they're meeting all their milestones and getting a good start on life. So I think there's two. There's sort of the practical, go to see my pediatric cardiologist, what kind of tests do I get? But then I think there's a lot more nuanced stuff about making sure that the kids are successful in the bigger picture, able to go to school, be developmentally on track, behaviorally, emotionally. And like I said, we want them to be adults that go to school, are successful, get jobs, have relationships with their family, and then future spouses, have kids, etc. So it's a really important part of what we do.
Thank you for that. The next question that we have from one of our viewers, I'm going to push to you, Dr. Eagle. It asks, are there Project Healthy Schools programs in Detroit and Flint schools to the extent that there are in other areas? And are you seeing the same success in these vulnerable areas?
Yeah, that's a really good question. The answer is yes. We have active school interventions in Detroit, in Flint, all over the state, frankly. And your question about the effectiveness, it's interesting. What we've seen is that in communities that have lower socioeconomic status in general, less access to parks, to physical activity programs, summer softball leagues, all of that, we generally see a bit of a higher risk child in terms of blood pressure, cholesterol, blood sugar. And ironically, when we've measured the success of our program, it does better in communities where there are less resources. And this is really good news because those are populations that we really need to consider. They're highly vulnerable and we really need to focus on them.
Kim, Dr. Eagle, can I just ask you a question? When you're treating the kids this way and the kids are learning these things, do they bring this home to their families, to the adults in the family?
Yeah, thank you, David, for asking that. And yes, one of the things that we've done is we've each of the 10 lessons in the interactive program, there's a sheet where the child will take it home to their parent and ask for their signature, indicating that, today we learned about the sugary content of fast food, for example, as one example. And by doing that, we're engaging the parent as oh, by the way, Jimmy learned today about heart health. And the other thing, David, that's interesting is middle schoolers, 12 years, 13 years old, they're becoming adults. And they're not afraid to take a lesson they learned in school and come home and say, this is the third night in a row we've had pizza. And it may not be completely unhealthy, but are there other options that we have here? And so that's one of the reasons we focused on middle schoolers. They're ready to begin to adopt some adult behaviors that they might carry for a lifetime.
That's great. Youth as agents of change. Imagine that.
Exactly.
That's absolutely fantastic. Dr. Colvin, I see another viewer question that's come in, which I'd like to try and push to you. It reads, symptoms connected to valve and rhythm problems are often hidden or asymptomatic. Do you recommend heart checkups? And if yes, could you recommend how I would get connected to a cardiologist accepting new adult patients?
Good question.
Luke?
So, if you have concerns, I think the first stop would be your primary care physician, where they can obtain an EKG or an echocardiogram if there are concerning signs and symptoms on exam. And following that, if there are if there's evidence of heart disease and arrhythmia, for instance, that can be picked up by an EKG. Or if there are symptoms that suggest an arrhythmia that are not picked up by EKG, then your doctor would refer you on to a cardiologist for additional testing. And that's the same thing with valve disease. An echocardiogram can typically pick up those pick up valve disease. And whenever there are symptoms, primary care generally refers over to us. But we also, we have a wonderful general cardiologist in our practice. And I know there's a number to access those cardiologists. So I would recommend that if there are concerning symptoms, that you reach out first to your primary, who could probably get you in more easily.
Yeah, that's great. Can I just make one addition to Dr. Colvin? First of all, for the public, we are open for business. So everything you said is totally square on. And what we're finding is, including a patient I just saw, people are afraid to come in because of COVID, and people are staying home with their heart attacks or maybe heart failure. And if you have symptoms, we're open for business. Do get care, because this other care is so important, and we have capacity.
I think that's a fantastic point. I'd like to squeeze in one more question for Dr. Eagle and for Dr. Oye to discuss. How has philanthropy impacted the Frankel Cardiovascular Center and Congenital Heart Center?
So I'll start. I would say that the power of philanthropy has been felt around our care, our education, and our research, but particularly in research and in education, it has been profound. The ability for young scientists to get started in a research track often requires some investment in their laboratory or a population study that they may do. And our philanthropists who are helping support young investigators, a new idea, those are absolutely huge. Another key area for us is fellowships that may cross discipline. Rick mentioned adult congenital heart disease. A fellowship for somebody to train specifically in that area for a year or two is massive. So I would say that our ability to reach our destiny is absolutely critically related to the degree and success of our efforts to raise funds from wonderful foundations and individuals out there who believe in our work.
Yeah,
Rick?
I think I'd echo what Dr. Eagle said. I mean, for us too, it's also important for patient care because it's different. You know, I said, you know, we've had patients from all 50 states. Probably about half of our patients come from out of region, meaning more than 2-3 hours drive time. And so they're also uprooting their families. They have to move. It's not like you live in Ann Arbor, but they have to bring their whole family here. They may have kids and have to figure out how to get them cared for. And so insurance will pay for the kids' care here, their heart care, but it's not going to pay for them to come here, move here. It's not going to pay for their food, for themselves, for their other family members, or childcare back home. So we also raise money, and I wish I had a poster for Save a Heart. I'd have product placement, but we have a fundraiser that's specifically geared towards raising money for the families. And as Dr. Eagle said, those advanced fellowships like adult congenital, they're not paid for by the med school or the government. We pay for them, and you pay for them with your generosity. And that's how we generate the next generation of advanced doctors. And then again, with research, as I mentioned, number one birth defect, 3% of our entire research budget for the United States goes to kids with congenital heart disease. Really, really small amount. So it is incumbent upon us, if we want to advance the whole field through research, that we raise the money through philanthropy and support that. So, oh, good. Someone just put it up on the chat, but there's a link for Save a Heart. So again, it's a free event. I would like everybody to feel free to come join us and be a part of this really great team, because you really are an important part of our team.
And something
Thank
that
you
David,
so much.
something David
Go ahead.
mentioned, the ability for us to attack COVID is largely dependent on our ability to have unrestricted dollars that we can immediately target certain aspects of the COVID-19 infection here. And David and our colleagues put together a portfolio of research possibilities in a matter of weeks. And we went from being victim to victor in attacking COVID and its effect on the cardiovascular system. That is a perfect example of how philanthropy can power us during a time of crisis.
Yeah, thank you. Thank you so much, all four of you, for all of the information that we've gone through, all of the questions that we've answered. As you pointed out, we have the Save the Heart Gala information in there. And we also invite you to be a champion during Heart Month and participate in our Follow Your Heart to Better Health campaign to benefit the Frankel Cardiovascular Center. And a link for that campaign too will also be placed in the chat. So before we conclude today's webinar, and it's been a real privilege to have these four panelists with me, I'd like to welcome Katie Schutt, Director of Development for the Cardiovascular Program for Michigan Medicine Development. We should have Katie on board any second.
Good afternoon, everyone. Thank you so much, Ed, and thank you so much to all of our panelists who joined us today. We feel so fortunate for your expertise and your willingness to chat with us this afternoon. Thank you also to our attendees. Your questions were fabulous, and we tried to address as many as we possibly could. I want to extend a sincere thanks to our donor community. We talked about it today, but the ways in which you've lifted us up, especially over the last few months, has been incredible. So thank you for supporting our research, clinical care, and educational efforts. We will be sending a recording of the webinar along with a link to our Patient and Family-Centered Care Fund, contributing to that effort, which enables innovation in patient care and supports our patients and families that come to us from across the country. Our next webinar for the Well Aware series will be on the topic of COVID-19 1 year later. So that will be on March 11th at 1 o'clock. We hope you can join us. Thank you all again, and we look forward to seeing you, and go Blue.